again, rotator cuff problems span a really wide range from basically low-level stuff, meaning inflammation, irritation of the tendon, all the way up through really pretty dramatic tears that are chronic and have been there a long time and are going to be very difficult. So just to start with, rotator cuff problems are super common. I sometimes joke around that if you're at a cocktail party and someone says, I've got this thing with my shoulder, whatever it is, if you guess rotator cuff, you're going to be right 9 times out of 10. It really occupies, in different ways, the majority of problems in the shoulder that we see. So first of all, people have heard rotator cuff. They watch baseball or sports, or someone they know has had a problem like that. What is it? The rotator cuff is a group of 4 tendons. And when we say tendon in the human body, tendons think of as a rope that connects muscle to bone. That's what a tendon is. And in the shoulder, you have 4 of them. Together, those 4 collectively are called the rotator cuff. They each have their own individual name, but they're 4 tendons. So problems in the rotator cuff can range from irritation, inflammation, things that people have heard of like tendinitis, bursitis, through tearing in those tendons themselves. Again, think of them as ropes. You can imagine a rope that's torn a little tiny bit or a lot or almost hanging by a thread, and the tendons of the rotator cuff can behave in just that way. For patients, they kind of fall into 2 camps of rotator cuff problems. The first camp is an acute injury. You're snowboarding, you're having a great day, you kind of lose control and you take a bad fall and you land with your arm out to the side and you get up and you can't lift your arm anymore. Well, something bad has happened, obviously. This is not just you have a bruise. Well, you might have had an acute tear of the rotator cuff, which is a true traumatic injury, you might say analogous to breaking a bone. Something dramatic has happened. That actually is the less common version. That only occupies 10 or maybe 15% of rotator cuff problems that I see. The vast majority are problems that occur over time, again, much like wearing out a rope or wearing out your shoelace. It doesn't happen all in a moment. It tends to happen little by little, and then sometimes a lot. What it means to patients is someone comes in and sees me with pain in their shoulder. They don't know what's wrong. They don't know what happened. They may or may not have had an injury per se. Maybe they had a bunch of small injuries. Maybe their shoulder was just sore and now it got worse. They're not sure what happened, but they know it hurts. It hurts with activities typically, such as reaching overhead, the classic one, throwing a ball, in the case of overhead throwing athletes. Classically, sleeping on the shoulder is really provocative of their pain. Often it's patients that when they can't get comfortable at night to sleep, that's what really brings them in. And we go down the road of starting to evaluate this. Again, this can affect all age groups, young and old, but we'll see someone who's had shoulder pain. We start off in the clinic looking at what the possibilities are, and as we start to direct our attention toward rotator cuff problems, we go down a specific pathway of diagnosis. So in terms of thinking about potential rotator cuff problems, someone says, well, my shoulder hurts. I wonder if this is really a problem. Do I need to see someone? Again, the person that had an acute injury, they know they have a problem. Maybe they've already come to the emergency room, or they really understand they need to be seen acutely. But again, the more common circumstance is someone that has some ongoing pain. It's not life and death, but they have the sense that something's not right and it's not getting better. And they've tried some stuff. Maybe they've looked up exercises on YouTube. Maybe they've taken some Advil, and it's just not working for them. So for most patients, again, if it's not a clear-cut acute injury, after 6 weeks, if their problem isn't resolving on its own, they should probably be seen and evaluated. For example, if it's a low-level inflammation, a little bit of tendinitis, a sprain or a strain, well, after 6 weeks, it may not be 100% better, but it should be clearly getting better. And it's a good marker in time. If you have pain that is persistent and not improving despite those other basic measures, after 6 weeks, probably someone should see you. Because problems in the rotator cuff, while they're not emergencies, they can be time sensitive. And ignoring them for months and months can really cause a problem in terms of limiting our ability to treat them and make them better. So if the person says, listen, it's been 6 or 8 weeks, it's not getting better, then I encourage them to come in and be seen. And I mean in person, not telemedicine or video. We do a lot of that work these days, particularly in terms of the pandemic. But part of dealing with shoulders in an accurate diagnostic fashion is a really good physical exam. I think it's really important for people to understand that pictures like MRIs or X-rays or other studies, CAT scans, those are helpful pieces of information, but they are not the be-all and the end-all for diagnosis. In the shoulder in particular, physical exam is really critical, particularly to distinguish some very different things, one from the other. And as an example, often I'll have someone show up with an MRI and it lists 6 or 7 different things that the radiologist has seen that are not entirely normal. But maybe 5 out of the 6 are essentially irrelevant. They're just normal aging or something that doesn't mean anything. But how does someone pick out the 1 out of those 6 that is really accurate as the source of their pain? Well, that's where physical exam of the patient really is important. So sometimes people think, well, that's kind of old school. Can't you do it on the video? It's more convenient. It is more convenient, but it's much less accurate. So I think physical exam is really critically important. So again, on timing, after 6 weeks, you have something that hurts that is getting better. That's a time to at least get it evaluated. Many times I see someone and I reassure them, no, I think it is just a sprain or something low level. That's fine. We're talking about doing some physical therapy or tuning it up. But really the thing I like to avoid is missing something that's time sensitive. So 6 weeks is a good number for something that's not an obvious acute traumatic injury. In terms of talking about treatment of rotator cuff problems, again, rotator cuff problems span a really wide range from basically low-level stuff, meaning inflammation, irritation of the tendon, all the way up through really pretty dramatic tears that are chronic and have been there a long time and are going to be very difficult. The good news is most rotator cuff problems fall into that less severe category. They're either less severe injuries or problems with the structurally problems with the tendon itself, or they just haven't been there long enough to be truly chronic, and they're much easier to treat. Most of those things I treat without surgery, in fact. Most things can be treated with a combination of medication for anti-inflammatory effect, physical therapy, injections, which can include cortisone shots, classic, and we're also doing newer kinds of injections, including stem cell therapies and PRP that some people have heard of. So we have some new tools at our disposal that we didn't have 10 years ago to really help promote healing without more dramatic intervention. But there are some circumstances where there are tendons that are structurally torn, and one of the problems in the rotator cuff is that while the tissue is alive, it has very little blood flow and it has a lot of trouble healing. So it's not analogous to your fingernail where it's completely dead and you can just trim it off and not feel it. But the rotator cuff really has poor healing potential, is what we say. And so a truly torn tendon it tends not to heal on its own, partly because it has poor healing potential, partly because it is, as I described, it's under tension. So again, there's that muscle connected to the tendon. It's pulling on it all the time. As the tendon tears, it tends to pull back, much like a rubber band would pull back if you cut it. And so with that tension or gapping, the tendon simply can't repair itself. So there are circumstances where we have to talk about surgery to repair tendons. There's no question about that. Again, the good news is that the technologies, the techniques that we use have advanced quite a lot, even in the last several years. In terms of materials we use, techniques that we use to do this, most of the repairs that we do can be done in a very minimally invasive fashion using arthroscopic techniques or small TV camera approach that people have seen or heard of. Most of those are being applied to the shoulder. And even in circumstances where the tears are much more severe, they're larger or they're more chronic or the tissue itself has deteriorated, we again have newer materials and techniques, including things that act as patches or reinforcements, so that there are tears that even 5 years ago we would have said weren't repairable at all, that we're now able to repair in large part. So the rotator cuff and the treatment of the rotator cuff has really advanced quite a lot in the last several years. So we're getting people better that we couldn't get better before at all. We're getting a lot of people better quicker with less invasive techniques. I've yet to meet the person who said it was really fun to have shoulder surgery or rotator cuff surgery, but it's definitely getting much, much better, and it's certainly much better than it used to be.